Okay, so talking about the case first. The case scenario was a 39-year-old male who came to the ER who was confused and agitated. After asking his wife, she gave the history of intermittent headaches and palpitation. He had lightheadedness and flushed skin on playing basketball, and she also said that he was diagnosed with hypertension and was given clonidine, but he felt sedated and therefore his physician asked him to take metoprolol. And he was agitated, diaphoretic on examination. His BP was 215 by 132 mmHg. He had papilledema but no retinal hemorrhages or anything else. So also his electrolyte balance was normal. His drug urine analysis was normal. There was no abnormality seen. So let's come to how are we going to draw the differential diagnosis. So I'm going to do it from the clinical features which I see. So confusion and agitated state, I would first think of anxiety or panic attack. Then coming to intermittent headache and papilledema. Also on examination he was agitated and diaphoretic. So that would mean essential hypertension. That is what I would first think of. Then he also had the history of usage of clonidine, and then he took metoprolol after he felt sedated after using clonidine. So and also when I came to BP, so 215 by 132, which was higher than 180 by 110, which would mean hypertensive crisis. And also he had papilledema. So also all these features would mean illicit drug use as well, but his urine drug analysis report was also normal. So this was about the differential diagnosis. It could have been anxiety, panic attack, it could have been essential hypertension, it could have been hypertensive crisis. So all these things. But then I saw that there was a CT scan given of abdomen. So CT abdomen was given, and there was an enlarged adrenal mass. So this depicted a tumor. So then I went back to this statement where they said that clonidine was replaced by metoprolol. Here is when I thought that with all these symptoms, they actually tell me that this is because of the adrenal tumor. These all must be features of paroxysmal hypertension, and probably due to the effect of metoprolol because of the beta blockade, opposed beta blockade effect. So my probable diagnosis would be pheochromocytoma. Okay, so now we are coming to the management of pheochromocytoma. So coming to the diagnosis part first. So we are going to do all the physical examination. We are going to look at the signs and symptoms, and when we suspect pheochromocytoma, we are going to do 24-hour urinary catecholamines. We can do take blood samples for catecholamines, and we are going to see that catecholamines, metanephrine, non-metanephrine, and DMA levels are higher than normal. And then to confirm the diagnosis, we are going to do CT or MRI scanning for the tumor diagnosis. Then coming to the actual treatment part. So the treatment of choice is excision of tumor, resect the tumor. But before doing the surgery, we are going to do pre-op preparation. So alpha plus beta blocking drugs we'll give 2 weeks prior to the surgery. We are going to start the patient on alpha plus beta blockers. So we can give phenoxybenzamine, or we can give prazosin plus propranolol, and sodium diet should be increased. If all these fail, we can give metyrosine for decreasing catecholamine levels, and or CCBs, nicardipine we can give. Then if excision of tumor is not possible at all, we are going to give the patient lifelong alpha plus beta blocking drugs, but we cannot give beta blockers alone. So why? But beta 1 adrenoreceptors are going to cause arrhythmia, palpitation. Beta 2 receptors, if stimulated, will cause vasodilatation, also in skeletal muscles. But if there is blockade of beta 2 receptors. So there is going to be unopposed alpha adrenergic stimulation, and that is going to cause hypertensive crisis. So that is why we don't give beta blockers at all. So that is about my treatment part.